Care beyond limits. Patients in care and nursing homes, prisons and asylum centres, and other sometimes highly charged environments all need podiatric care. From safeguarding protocols to duty of care, what do podiatrists need to be aware of? This story for the Podiatrist was written by Anna Scott. Part 1. Introduction. Podiatrist Thomas Calderbank has run Care Home Podiatry, which delivers foot care to patients in care and nursing homes for the past 5 years. As a business, we have noticed an increase in care homes employing foot health practitioners or other foot care providers, he says. Delivering care to residents differs in some ways from mainstream clinics. Podiatrists must consider key legal issues such as ensuring informed consent and assessing the patient's capacity to make decisions, which is particularly tricky to navigate due to the high prevalence of conditions such as dementia, Thomas says, and it's possible that patients lash out. Often these situations arise because of pain, fear, or confusion, and are associated with a diagnosis of dementia, Thomas says. So understanding a resident's background and potential triggers is key to prevention. Patients in prison might also become aggressive. Emma Barlow, a specialist podiatrist, runs a clinic in 2 large prisons, attending weekly for full and half days depending on patient need. However, she says, "I've always felt very safe. I guess when you first go in, you have a lot of assumptions, but they are just normal people. The building itself is scarier than anything. And once you are in the health centre, the guys are grateful for any kind of healthcare. It's like a normal health centre. Prisoners put in a patient referral form. I vet these and list them for my clinic. It's exactly the same as mainstream podiatry. I just see whoever has got an issue." The rest of the week, Emma delivers care in houses, clinics and wards. Prison is certainly a different environment from a mainstream clinic, with guards outside and panic alarms for staff. It's one of a number of settings: care in nursing homes, psychiatric and secure hospitals, and asylum centres, in which podiatrists work that may prove challenging. Part 2. Podiatry provision. While the college does not hold specific data on the numbers of podiatrists employed within these settings, Professional Support Officer Katie Harwood says, "Podiatrists may be employed directly by the NHS, local authorities or private providers, or may work independently on a contractual basis. Provision varies regionally, depending on local commissioning arrangements and patient need." In England and Wales, the NHS either directly provides or commissions healthcare for people in prison, says Gareth Lloyd Hughes, head of podiatry and orthotics for the East Area at the Betsy Cadwaladr University Health Board. As of 2024, there are 142 prisons in the UK, including 5 adult prisons in Wales, Gareth, who has experience of working in prisons, says. There's also very little published data on the number of podiatrists working in the social care sector. What we do know is that with around 441,000 people living in adult care homes across the UK, the demand for foot care is enormous, Thomas explains. In practice, most podiatric care in these settings is delivered by private or independent practitioners, as only a small proportion of residents qualify for routine NHS services. While NHS input varies by region, independent practitioners remain the backbone of podiatric care in care homes. Part 3. Complex needs. Patients in these settings require a wide range of podiatric care and often present with complex health needs and multiple comorbidities. These include peripheral vascular disease, pressure damage, nail pathology, and skin breakdown associated with reduced mobility or cognitive impairment, and insecure or unsafe footwear, and poor foot hygiene due to reduced capacity for self-care. In care and nursing homes, residents are frail, may have dementia and reduced mobility. They are particularly vulnerable to complications such as diabetic foot problems, ulcers, and an increased risk of falls, Thomas says. Importantly, these residents are still individuals with the same podiatric needs as anyone else, so treatments such as biomechanical assessments, musculoskeletal care, and even nail surgery may still be required. Research also highlights the role of podiatry in falls prevention, and with people living in care homes being much more likely to suffer a fall, it is vital for practitioners to understand how foot health influences balance and mobility. In prisons, all the usual clinical podiatric risks and pathologies are present. But we do tend to see more of the conditions common to a younger, more active patient group, such as cryptotic nails and MSK issues related to the gym and football, Gareth says. We do see more communicable dermatological diseases such as fungal skin infections, he says. Even if they have their own showers, they are often coming from other prisons where communal showers are still common. Less common in the community setting is this significant and initially shocking negative impact of intravenous illicit drug use to the lower limb vascular systems. Ingrown toenails are a perennial problem. Emma says, "In Scotland, we don't cut toenails. All the prisoners have to cut their own. The nail clippers they have must be approved, and I cannot give files away to patients to help self-manage." Part 4. Equipment use. Otherwise, there aren't any restrictions on the equipment that can be used by podiatrists in prisons. The prisons order my equipment, and so I still have full access to scalpels, the nail clippers, files, and so on. Emma explains. But there are great differences in the risk management of equipment, Gareth says. All are single use and disposed of immediately after use. The patient will not have left the chair. They are never kept within reach, as should be the case in the community. We have a separate back room to the clinical room, and instruments are stored there and accessed on a patient-by-patient basis. Each instrument is counted at the end of every session to ensure it tallies with the stock levels. This is recorded by us and saved by the prison, Gareth adds. Otterform, which could be used to take impressions of keys, and tube gauze for dressing, which could be used as a ligature, are also put back immediately after use. But otherwise, Emma says, you're probably as safe in a prison as you would be working elsewhere in the sector. Part 5. Duty of care. The legal duty of care is the same as that for the clinical population. Patients in prison are entitled to receive healthcare equivalent in quality and accessibility to those in the community, Gareth says. The obligation to adhere to the HCPC standards of conduct, performance, and ethics remains unaffected by the location or cohort. Give safe, effective, and evidence-based care. Maintain confidentiality and dignity. Obtain informed consent before treatment, and recognise and act on safeguarding concerns. Podiatrists have a professional and legal obligation to safeguard vulnerable adults, completing appropriate safeguarding training, usually to level 2 or 3 depending on role and setting, following local safeguarding policies, and undertaking disclosure and barring service or protecting vulnerable groups checks where applicable. As usual, podiatrists must follow infection prevention and control, sharps handling and decontamination guidance. Katie explains, legal considerations include capacity and consent under the Mental Capacity Act, 2005, deprivation of liberty safeguards, and safeguarding legislation relevant to adults and children. Treatments should be delivered safely and respectfully and be tailored to each patient's individual needs, Thomas says. Safeguarding needs to take centre stage. Podiatrists need to be vigilant about protecting vulnerable patients and maintaining their confidentiality. Part 6. Safeguarding protocols. To protect themselves, Katie says, podiatrists should follow the local incident and violence or aggression policy of their employer or host organisation. Withdraw from the situation. If personal safety is at risk, report and document the incident in line with governance procedures and seek occupational health or psychological support if they need to. The college has a wellbeing support service that members can access, and our position is clear. No podiatrist should continue treatment if their personal safety is compromised, and we support a zero-tolerance approach to violence and aggression. Thomas explains that if an incident occurs in a care or nursing home, the podiatrist should remain calm, de-escalate the situation by stepping back, and stop treatment immediately if it's unsafe to continue. Knowing when to stop and seek support is part of maintaining professional boundaries and ensuring safe practice, he says. Before treatment, podiatrists should communicate with care staff to identify any known risks or behaviours, and, where possible, ensure a staff member familiar with the patient is present during the appointment. The induction process Gareth undertook to work at the prison he worked in was significant and lasted a full week. And as part of that, a large amount of training was in relation to risk assessment and protocol. In reality, in all my 7 years, I have never seen or had any violence or aggression with the healthcare section we work in. Although I am sure on the prison wings this will be a different matter, he says. But if they did, the process would be twofold. First, press the alarm button an arm's length from my working position, and second, shout to the guard who is 3 meters away outside. Part 7. Support for podiatrists. The level of support podiatrists working in challenging settings receive from their employer varies depending on their working arrangement. NHS podiatrists typically have line managers, occupational health teams, and staff wellbeing services. Independent practitioners providing services in these settings should ensure they have a clear service level agreement with the host organisation, Katie says, adding that members can contact the college's professional support officers or employment support officers for advice or guidance. Thomas recommends independent practitioners build a strong network of colleagues, engage in CPD, and maintain open communication with care home teams to ensure ongoing professional and emotional support. Good care home partnerships make a big difference, he says. When homes are proactive, providing clear communication, risk information, and assistance during treatments, it helps create a safer and more effective working environment. Employers and care home managers can also support podiatrists by offering regular feedback, space for reflective practice, and access to training, particularly in areas such as dementia care, safeguarding and managing challenging behaviour. In prisons, healthcare teams are closely knit. Regular supervision is in place, and the close proximity of GPs, nurses, physios, dietitians, occupational therapists, dental professionals and pharmacists makes it a diverse, rich and supportive place to work and learn, Gareth says. Regular safety updates and training are provided, and processes and protocols are robustly shared and updated too. He says working in prisons can be a very interesting and rewarding change from the community podiatry routine. On the whole, I have never met a patient group more interested in their health and keen to resolve their issues, he adds. Emma adds, I'm not there to judge them. I'm there to treat them. Working in the care sector is hugely rewarding too. The most experienced podiatrists are able to combine technical skill with compassion, communication, and the ability to see beyond the task, says Thomas, recognising the resident as a whole person, not just a foot. Part 8. Working with asylum seekers in the community. Like all patients referred to podiatry services at NHS Grampian in Scotland, refugee and asylum seekers are assessed on their presenting medical and podiatric needs and, where required, a person-centred care plan provided. Following triaging of the podiatry referral, the patient will be contacted and offered an appointment, says Lynn Morrison, Director of Allied Health Professions at NHS Grampian. The assessment would be undertaken by an HCPC registered podiatrist, who may be employed on a full or part-time basis. The location of the appointment may vary across Grampian, but most are encouraged to attend an outpatient clinic. Home visits are typically only for those who are completely housebound. All podiatrists undertake appropriate training to ensure patients are safe, protected from harm, and the podiatrist is trained to recognise any signs associated with this. Podiatrists have public protection training, which covers adult and child protection, and equality and diversity training is a mandatory requirement. NHS Grampian also has a number of other policies in place to support all staff, including health and safety and lone working. NHS Grampian ensures the appropriate policies are in place to support all staff, including podiatrists, through a mix of nationally agreed policies and local policies. NHS Grampian adheres to the NHS Scotland staff governance standards that set out what health boards are required to do to support all staff and what the staff responsibilities are. Lynn says, all podiatrists are provided with appropriate time and training, which is mandatory for their clinical role and to support their professional development. Other supportive policies include time for supervision and appraisal, and access to wellbeing support. Part 9. Top tips for podiatrists looking for experience in these settings. 1. boost CPD competencies in areas such as dementia awareness, capacity and consent, de-escalation strategies, mental health awareness, personal protective training, safeguarding and working with vulnerable adults. 2. Pay attention to the relevant legal frameworks, including capacity, consent, and confidentiality, as they are especially pertinent in these environments. 3. With prisons, ask to attend as a visitor to shadow the healthcare team first. The prison regime can seem oppressive initially, with multiple checks and locks, Gareth says. Emma agrees. Speak to local clinicians going into prisons. And 4. For care and nursing homes, the most valuable starting point is developing strong communication and empathy skills, Thomas says. It's also helpful to approach care homework with adaptability and a team mindset,